For lung cancer, gefitinib is certainly the first drug for which we can apply the concept of personalized medicine. We need to know if the patient has the target for gefitinib or not, and the difference in outcome in mutated patient and wild-type patient is such that it is mandatory to look for the mutation and treat the patient with Iressa if he has a mutation. Absolutely. This is the first example in non-small cell lung cancer. We have seen other examples here today at ASCO, but at the present time, for a drug available for any practicing physician, gefitinib is the best example. Well, it is true that the only data that we have right now were generated in Asia, but we also have some retrospective data in a Caucasian population, and in second line in the INTEREST trial, most of the patient population was Caucasian. And when we looked at the outcome according to mutation, we clearly can conclude that in patients with a mutation, Iressa is working whatever the ethnicity, and also is working whatever the line. So whether you are Asian or Caucasian, in first or second line, the benefit will be the same. The hazard ratio are about the same. A general conclusion that can be drawn is that a patient from Asia have a better prognosis. But the magnitude of the benefit from gefitinib, as long as we have the mutation, is the same in Asian and Caucasian. So whatever the line, whatever the ethnicity, there is no difference. I think so. We have seen the example of Iressa with the EGFR mutational status. We also have seen here at ASCO all the drugs that work on specific mutation, and we will have to get as often as possible a kind of a cartography of mutation to decide for a given patient what treatment we should give. And I would say regarding the use of gefitinib that it is important to have enough material to look for the mutation, and if the patient has a specimen that was taken several months or several years before, it may be worth rebiopsying to get a fresh material because the mutation may be acquired. Now the other question is, what patient should we test for mutation? We know that it's more often in adenocarcinomas. The gender, male, female, does not make a big difference, but the key factor for the difference is a smoking history. And in the IPASS study, there is a clear cutoff value of 15 pack a year. That makes a big difference. People with less than 15 pack a year have a significant higher incidence of mutation than patients over 15 pack a year. In Asia, there was a poster here at ASCO showing that this cutoff in Caucasian is probably 10 pack a year. So a patient with a small exposure to tobacco with adenocarcinoma, in my understanding, should be tested.